Pleasure of introducing this panel this afternoon to talk about local quality improvement efforts, what it looks like at different institutions. When we were thinking about this conference 9 months ago, the big theme that came out of it was how do you make QI local? And that's what this is built around. So this will be kind of the pinnacle of everything we've talked about at this conference today. So we have 3 different institutions represented here today and 6 different speakers, so we'll give a different perspective. And I'm going to go through and introduce everybody with their bios. First is Dr. Mambarambath Jaleel, who is the Associate Chief of Clinical Affairs for the Division of Neonatal and Perinatal Medicine at UT Southwestern. He's an Associate Professor of Pediatrics at UT Southwestern Medical Center. He did his medical school training and pediatric residency in India. After completing his fellowship in neonatology at Canberra Hospital and the University of Sydney in Australia, he became a member of the Royal College of Pediatrics and Child Health in the United Kingdom. Then he moved to the United States. He's currently Associate Chief of Clinical Affairs for the Division of Neonatal Perinatal Medicine, as I mentioned. He oversees clinical operations in 4 NICUs attached to the division. He served as Medical Director for Parkland Hospital's NICU in Dallas for the last 10 years, and as Medical Director for this 96-bed teaching facility NICU, he created a unique neonatal quality improvement program and a culture of quality improvement for with 22 to 24 ongoing structured quality improvement projects using statistical process controlled methods, and he'll be talking briefly about some of those today. Our next speaker is also from Parkland Hospital, Liz Moore. She's the quality improvement coordinator for the level 3 NICU. She's a registered nurse there for the past 18 years and provides high-quality nursing care for patients and mentoring nursing staff. She managed the Nurse Policy and Procedure Program for nearly 10 years, integrating evidence-based practice throughout the hospital's newborn systems and services. In 2018, she began developing her current role as a quality improvement coordinator, building a unit-based program to integrate local quality improvement projects and hospital-wide activity in a hospital-wide structure. She obtained her bachelor's degree from Baylor University in 2002, and she's currently working on a master's of healthcare quality and safety through Johns Hopkins Bloomberg School of Medicine. Our next speaker is Dr. Karl Wehner, who's the neonatal medical director for the level 2 neonatal services at Shannon Medical Center in San Angelo. Dr. Wehner is a board-certified pediatrician who's served the community in San Angelo for over 30 years, providing pediatric and neonatal care services. He attended medical school and completed his residency at Baylor College of Medicine in Houston. He served in many leadership roles during his career and currently is the neonatal medical director for the level 2 neonatal services at Shannon Medical Center. He is an active member of many professional organizations and community organizations and was recently honored by the Boys and Girl Scouts of San Angelo as one of the 2019 pillars of our community. Our next speaker is Stacey Elizondo. She's the Administrative Director for Women and Children's Services at Shannon Medical Center, also in San Angelo. She received her undergraduate degrees at San Angelo University and her graduate degree from UT Arlington, and pursuing her Master's of Nursing. She began her nursing career in 1973 as a staff charge nurse with medical surgical patients. She's been a nurse for 27 years, working in perinatal leadership roles for the past 16. Currently, she oversees operations of the perinatal and pediatric service lines at her organization, including the level 2 maternal and neonatal programs. She serves as co-chair for the Perinatal Care Region Committee for her district. She's an active member of many professional organizations, including the Texas Perinatal Association, and she resides in San Angelo with her husband, Santos, and her daughter, Sophia. Next speaker is Marina Hoffman. She's the Director of Women's Services at Peterson Regional Medical Center in Kerrville, Texas. Marina's been practicing primarily in the obstetric field for the past 33 years. She graduated from Baylor University. We have a theme here. Louis Harrington School of Nursing. She received her Master's of Nursing in Leadership Management from Western Governors University. Most of her experience is in acute labor and delivery care, although she's served as a perinatal educator and team leader for the maternal transport team at Methodist Children's Hospital in San Antonio, where I first met Marina. Currently, she enjoys serving the Texas Hill Country community as Director of Women's Services at Peterson. So we're glad to have her here as well. And our last speaker, and then you'll be done hearing from me, Dr. Sharrel Carlton is Perinatal Medical Director at Peterson Regional Medical Center. She's a board-certified OBGYN who's been practicing for the past 27 years. She's a graduate of the Keck School of Medicine at the University of Southern California and a proud veteran of the United States Air Force. Dr. Carlton has the privilege of practicing military, hospital, and private practice settings. She's held numerous leadership roles in her career, including chairperson for OBGYN at 2 Oregon hospitals and managing partner of a large women's healthcare practice in Portland, Oregon. She currently works in a group practice with 5 midwives and 2 OBGYNs and serves as perinatal medical director at Peterson Regional Medical Center in Kerrville. So please help me welcome our panelists today. So I don't think anybody has slides, right? So we're good. So we're just going to talk, we're going to have a conversation here, and we'll just kind of go down the panel and have the teams kind of talk about what they're doing individually and then what they're doing as a group. And I thought the first question I would pose to the panel is, just tell us a little bit about what your center looks like and the population you serve, and what are your quality improvement priorities you're working on right now. And the third part of that question is, how at your institution do you pull things from the bedside and bring it up to the level of your quality program? Because that's a question that we've heard during surveys, when we do surveys and when we've been surveyed, is how do you bring that element of quality improvement that something's found at bedside, how do you bring that up to the level of your quality improvement program? So let's start here and work our way down.
So I'm the medical director for the NICU at Parkland. Parkland Hospital is a county hospital for the Dallas County, and more than 95% of our patients is Medicaid patients. And we have about 13,000 deliveries a year, and more than 90% of those mothers who come in have prenatal care delivered within the Parkland hospital and health system. Now, the NICU at Parkland is a 96-bed NICU, which is a single patient room, all on one floor. And the delivery rooms and the operating rooms are on the floor below. So we moved into this brand new structure, not brand new anymore, in 2015. And we also serve an academic mission with research, and at any given point, we have about 22 to 24 research studies going on in the NICU. And from the education point of view, we have about 12 neonatal fellows and more than 100 pediatric residents who come through, rotate through the NICU, and also medical students, neonatal nurse practitioner students, nurse residents, and multiple others. We serve them as well. So it's there's a significant amount of turnover on a month-to-month basis and year-to-year basis. You can imagine that. Parkland Hospital is also a part of the Southwestern Medical District. It's nested within a high-risk maternal, fetal, and neonatal tertiary care program. It has a level 4 maternal center with a high-risk OB. We also have a fetal program and another level 4 NICU, that's the Children's Medical Center, which is connected to Parkland, and where there is a level 4 NICU and a cardiac ICU as well. So when we started initially, about 10 or 12 years ago, we used to have somewhere around 2 or 3 quality improvement projects, which usually is initiated by either an enthusiastic resident or a fellow. It would go well for a year or two, and when the fellow leaves or the resident leaves, it would all fall apart. So we started thinking about how can we sustain this? How can we try to make this a continuous improvement process and create a program around it? And so initially we started off with having some of the faculty members and some of the nurse practitioners and nurses go through a structured program through the medical school. It's called the Clinical Safety and Effectiveness course, where you pick up a quality improvement project and over the next 6 months, stepwise go through that quality improvement project, and they walk you through that, creating the SMART aim, creating the a project charter for that, identifying outcome measures and process measures and balancing measures, and then they help you through that. And I did that, and a couple of my other faculty members did that too. And I found it really, really helpful, really beneficial to do that. And that started off a process, a program within the NICU. Once we identified, okay, these are the tools that we can use to create a program. And so we started off, and then by about 4 or 5 years, it started catching up and catching interest and getting interest of the staff. So by somewhere around 2015, we had about 15 to 18 quality improvement projects going on at any given time. These were structured quality improvement projects with a project charter and a team. Then very soon we realized that, okay, this is getting too unwieldy because one is how do we get this information to the staff, because all these quality improvement projects were happening in a silo of their own. So the people who are involved with the project would know the project. People who are passionate about this topic would know about the project, but it is not common knowledge everywhere. And then there would be improvement projects which would butt head against each other. There was a project which was looking at reducing phlebotomy and blood draws. And then there would be another one which would look at, okay, we need to do blood checks at 0 hours, 8 hours, 12 hours, 24 hours, and stuff like that. So it started becoming too out of hand for us. And so that's the time when we thought, okay, maybe we need to create a structured program which can sustain all these the quality improvement projects that we are making, which we are creating. Also integrate the nurses and the education and the staff around and get them to know about the projects, and also have accountability about these projects which are being created. Most of these projects were because people are passionate about what we do, and they would take time off just to do the project, but there was no structured time given for them. And so if something else comes up, this goes to the back burner, and yeah, we'll get there when we want to get there. Would be the usual way of dealing with this. We wanted some more accountability for ourselves. And so we started thinking about creating a neonatal quality improvement council. And eventually we got there, and we've started that in 2019. And I would let Liz talk more about the Neonatal Quality Improvement Council. Liz.
Hi, so I took Jaleel's challenge and became the quality improvement coordinator, and was given this bundle of projects that were very big projects that people were passionate about, but they weren't used to speaking to each other maybe all of the time, and I didn't actually know all of the projects. I kind of found them out as we went along, but my job was to start coordinating the communication between the projects and the leadership of the unit, and then get all that information out to the staff. So the council itself, we called it the Neonatal Quality Improvement Council, and NeoQuick for short. So if I say NeoQuick, it's the council. We established goals of providing a framework for improvement to help streamline these projects. Not everybody that was leading a project had had the opportunity to take the clinical safety and effectiveness course. So they were relying on somebody to kind of guide them along that way. And with as many projects as we had going, the people who had taken the course just didn't have the time to guide all of these people. So that became my job. So I took the course, and I also did the Institute for Healthcare Improvement course to help guide the different groups in developing a project and providing a structure. The NeoQuick adopted the IHI model for improvement as our guiding tool and have all of our projects design theirs around that. The NeoQuick goals also wanted to expand involvement within the unit by bringing the ingraining QI into the work culture and building cooperation between the teams and specialties. So one of the other roles I did was, as people were coming up with their ideas and their projects and they would come to me and we would talk through it, I was able to suggest, hey, you really need a speech therapist on your team because your project, here's a person that can do this for you and can really fill out your team and make you have a really well-rounded team. So then the council meets monthly, and one of the features of our council is that I maintain a full dashboard that has every project's measures on it. And every month we sit down in this meeting with all of our team leaders. It's open to everybody. We have nurses, we have respiratory therapists, medical, leadership level, bedside level. Everybody is welcome to this meeting, and we go line by line and we review where are you in your project today? What does your data look like? What obstacles did you come up with this month? How did you resolve those? And it's really great for keeping the unit talking about your project, talking about your intervention, and then they remember why they're doing it, and they remember what your intervention is, and it's really fun to celebrate. Oh, look what you did this month. You made this improvement happen. Great job. And then we celebrate publications, we celebrate presentations, and it's a really nice forum for us to keep this QI culture happening.
Dr. Wehner?
Okay, in the interest of time, I'm going to yield initially to Stacie to talk a little bit about our size and population.
Well, as Dr. Ramsey mentioned, we are out in West Texas, and we cover some of those counties that have the cattle and not the people. And we are a relatively large hospital, kind of in a rural area. We have 441 beds, but we are 100 miles away from anything level 3 and about 250 miles from anything level 4. So we're still considered rural, and we're a full service hospital for adults, I would say, but when you think about pediatrics and neonatal care, we do not have those specialty services in our area. We cover 15 counties in that region. We have in our neonatal services, we have 4 critical care beds and 10 special care beds, and then the rest is well baby. And in our maternal services, you know, we have 10 OB providers and 10 pediatric providers. We do not have neonatology. We do not have hospitalists. We don't have anything like that. So we have OB providers and pediatric providers working in their offices, taking care of patients in the hospital, seeing them, and follow-up care. We do about 1,300 to 1,400 deliveries a year. The vast majority of our patient population does receive prenatal care. We're about 65% Medicaid. And so for us, Quappy looks quite different than it does from Parkland. I love all the resources that they had, but it doesn't seem to work out for us that way very often. We all know that rural usually equals less resources. So I always say we have to wear lots of different hats and do lots of different things to get things accomplished. And if we are working on 5 things at one time, that's a tremendous amount, and we're doing well. And kind of how perinatal Quappy was born for us was out of our own ignorance that we didn't really know what we were doing. We had what I call the traditional quality department in the hospital that's looking at core metrics or joint commission requirements or all your regulatory type stuff, but we weren't really a part of that other than we knew how we were trending on that data. So as the designations came about, we really started thinking, well, what does this mean for us that, you know, work here in these units every every day, and what does this mean for our nurses and our providers? And so we really started, from the bottom up with writing a policy and starting a schedule of meetings and really learning what quality was about. Our organization uses the lean methodology for process improvement, and so all of us on the nursing side and our nursing leaders and now some of our frontline staff are trained to think that way, and it's kind of been the goal of our organization to really grow a culture of everybody in the hospital, in the whole organization, really understanding that they could make a difference, but on what level. And every idea is a good idea, but maybe not something that we're going to be able to successfully implement. We do have to go back and look at our resources and things like that. So that's really the structure that we have used to bring projects forward. And a lot of the stuff we're working on is similar to what Dr. Briggs mentioned earlier in the day today. We're working, whenever you're looking at how quickly you can get the resources you need. What are your times for urgent response of your providers from radiology? How quickly can you get those medications into that patient? What's your staffing like? All those type of things. So we're doing all of those things pretty much the way the rest of the state is in rural areas.
And I'm just going to answer, I think one of your questions is, how do you get quality from the bedside? And and one of the advantages of being a smaller level 2 is everybody knows each other. Respiratory therapists are our friends, and same with everybody. So it's a lot easier for us to communicate on all levels. And so as far as getting to the bedside, we've learned a couple of things. One is that we now have the nurses, all the nurses do audit the charts. And so that they begin to see what they do matters and can start to pick up things that we're missing. And so we get it from the nursing level at the very beginning, also the cardiology, the cardio techs and the respiratory techs. We meet on almost a daily basis just because we're around, and we discuss what problems we had, and then can that be something that we need to take, is that something we need to take to quality or to QAPI? So we begin on that level. So it's a lot easier at our level because there's a lot fewer of us. The other thing that we learned is that you have to, it isn't physician-led as much as it is at the bigger institutions, because we are not in the hospital nearly that much. If you look at most of our time is actually in our offices from 8 to 5. And so that the day-to-day kind of thing to make sure that you close the loop, that you get everything done, we're dependent on Stacie and the nursing staff and all the other specialties. We do meet and make sure all those things happen, and I am there making rounds every day, but it's not, I don't stay in the hospital. So it's a lot different how we have to do it with the physicians. And it's still an ongoing thing for us to improve, and so as physicians, this has been a new process for us. We all think we know everything, and so pointing out, looking at our mistakes, that kind of thing has become, we've done it for a long time, but actually focusing on the neonatal aspect, it happened when it was designated, what kind of designation we wanted. That's when we really got behind the ball, and now we're starting to become a pretty good unit. We do well at looking at ourselves. We're doing better all the time at looking at ourselves.
Thank you. Ms. Hoffman?
I was going to yield to Dr. Carlton to describe the...
Sure.
So Peterson Regional Medical Center is a nonprofit hospital in Kerrville that has 127 beds, and it is not part of a hospital system. It is its own medical entity and has a medical group associated with it, Peterson Medical Associates. The OB unit that we have, Women's Services, has 4 labor and delivery beds, and we have 10 postpartum beds. And we also take care of patients that are GYN patients or post-op surgical patients that have breast surgeries and things like that. So it's women's care is our unit. Our situation is unique in who the providers are in our facility because we have a single medical OB-GYN group that is employed by the hospital, and so there's 3 OB-GYN physicians and we have 5 certified nurse midwives. So we are married to the hospital, so it's a very unique situation as far as the culture. We are all Peterson, and so I think that gives us somewhat easier buy-in as far as policies and practices and all being on the same page. We have 24 7 coverage by neonatal nurse practitioners for our pediatric patients, which is a newer thing since I've been there. I've been there a little over 2 years, and that has really helped with our level 1 nursery coverage, and not relying on the community pediatricians who have been aging and trying to get away from hospital practice. So that's really helped our acuity care in our facility. I'll let Marina pick up about the quality stuff.
As with most small rural hospitals, the leadership wears multiple hats. And so I'm the director, yes, and so I'm in charge of FTE management, productivity, hiring. I'm also the educator, so we train nurses through a labor and delivery residency. And then I've learned a lot about the quality piece of it. Leadership, directors, and even shift leaders are trained through the Lean Six Sigma training, and we do DMAIC as opposed to the PDSA, but it's all the same QI training. What I wanted to say is that what's unique and has really helped us at the rural facility is that because we're small, we might only staff with 4 or 5 nurses in the department at any given time. And that's to take care of all the couplets and the GIN patients and the labor patients. So we might only have 2 labor nurses on deck at any given time. So when we have an obstetrical emergency, it's all hands on deck, but you've got 3 of you. So in a massive transfusion situation, you need to engage with your ICU, your house supervisors. Everybody has a role. And so it's been a lot of fun implementing the bundles, and especially with our massive transfusion protocol recently, when we've had to call it a couple of times. Engaging with the ICU nurses, they can help you, and shouting from the mountaintop of what the issues are in obstetrics is really, really important. You need to let them know what the problem is, what a hemorrhage is, what the significance of that. How can you help us? They're really good IV starters. They can manage all the blood transfusions. We just kind of give them that. You just manage giving all the blood units, and we'll take care of from the waist down, and including them in simulations, along with the ICU nurses, the house supervisors. Everybody plays a role. Anesthesia. One thing that's really helped garner the leadership support for what we do in our small department, we deliver about 500 babies a year, is that most hospitals have this brief administrative meeting every morning where you huddle and everybody talks about what the situation is in your unit. We're not afraid. We're all about transparency, and we call out what's going on in our department. And if we had a hemorrhage last night, then I'll report. We had a hemorrhage last night. QBL was 2,000, and it's alarming to some of the CEOs, the CFOs who are present in the room. They're like, that's scary to them to hear that, but we had a good outcome, the patient's fine, didn't go to the ICU and stuff like that. They want to hear that, and we report that very briefly in our BAM meetings, but that raises the awareness of, it's one thing to say high-risk obstetrics to a CFO, and they don't really know what that means, but when you say this lady could have bled, she could have died, then they're asking you, what do you need? What else do you need? And so they are, Peterson, we're fortunate. They've been very, very supportive of what we need, even being able to, ask for half an FTE to help me with the quality piece of it, in addition to the clinical supervisor that helps us lead the unit. Anyway, you got to think outside the box a little bit with small rural hospitals. We have a Peterson Foundation that came to us. They're like the fundraising part of the organization, and they asked us, they put women's services as their goal to support that 1 year, and they did fundraiser, and they said, what do you need? And so I was like, oh, this is kind of nice. So we, at a small rural hospital, you don't necessarily have all the supplies and equipment like a big medical centers do. We had a need for a transport isolette. We didn't have a transport isolette. To get a compromised baby from the OR to the nursery was always cumbersome, trying to move the warmer and all that stuff. So they did fundraising and got us a transport isolette, which the neonatal nurse practitioners loved. And then the other thing that they were able to help afford for us is the really nice high-tech obstetrical hemorrhage cart that has the refrigerated medication drawer. And so just because you're small doesn't mean you can't have. You just need to ask. You need to make people that write the checks, you need to let them know and let them be aware of what your needs are. And so they know, because I report them at every BAM meeting, how often we have hemorrhages. Or any other critical situation. But sometimes that really, really works, and we're really fortunate at Peterson that we get that support.
Go ahead.
I do want to add something about quality that I've learned over the last. We didn't have even a neo director. We had a director of the whole of pediatrics, so they did both things, and we divided it up once we started the deciding what level we're going to be. And one of the things that I've learned is what happens is some of the things that happen, we are only as good sometimes as our own experiences. And so what's happened in pediatrics is there's 9 of us, 9 pediatricians that are involved in the nursery, is that when we go to conferences, the conferences now really orient either toward hospitalist kinds of things or outpatient kinds of things, and neither one of them talk about neonatology. It's way over here. So for years now, they're going to, since those have changed, now we're having to really focus on where can we go so that we learn how to look new things. So just coming to this particular conference, I don't know how many other general pediatricians are actually out there, but the Safe Sleep Initiative is an easy thing for us to go ahead and enact. So we're going to start doing the Safe Sleep Initiative. And so we need to continue to, and the same thing with the hemorrhages that happened for the OBs in our hospital. That's been a major step forward. Those kinds of things are all things that can be done, and so that it's. But you have to get to the places. We have to get ideas from other people, and that's kind of what I've learned. One of the things that I've learned as I've tried to become part of the quality initiative is where can we improve that we don't know that we can improve, and that's been important.
Perfect. Great segue. I want to just touch on one thing that was mentioned. There's some good courses out there that you can take advantage of to train your team up for quality improvement. If you're part of the UT system, the Clinical Safety Efficacy course is a really robust program. Goes over a 6 to 9 month period of time. You do a project with it. That's within the UT system. The IHI course the series was mentioned. Some institutions will have that purchased so you can get in for free, but it's easy to sign up for and do the modules. And then anybody that was here on Wednesday afternoon, Amanda Wehner set up the QI 101 or QI Academy for the collaborative to kind of teach us all how to do quality improvement from the ground up, from basics to more advanced things. She's already working on 202, so hopefully 201 or whatever. So those are, be looking for those things, because we can't do everything. We need to train our unit up so that other people become passionate, become leaders for the QAPI down the road. A couple things came up during the discussion that'll lead into my next question. Getting information from your QAPI or quality program out to your staff is a challenge. Getting physician engagement is difficult, especially in smaller centers. I just want to go on the panel and just have you each talk a little bit about other challenges that you've encountered from your quality program, and how did you approach that?
Yeah, you mentioned about the difficulty getting that information to the staff, and also you mentioned about making staff get passionate about this. I think that's the key. Yes, things can come from leadership, the commitment can come from the leadership, but unless you get the staff at the bedside passionate about it and let them lead this, it doesn't sustain. The program doesn't sustain, and that's what we have found. So I think it is important for us to get the information out to the nurses. Initially, when we started these QI projects, we would come up with ideas and say, these are the measures, these are the things which we will do to improve quality, and let the nurse or let the RT do it. And for them, not knowing why we are doing what we are doing was difficult, and also it didn't lead to buy-in from the staff. So one of the things that we did was use web-based tools and web-based programs. So one of the things which we did was create a web-based tool, a decision support tool. It is online. It's available on the intranet for all the users within the campus. And we made an icon on the electronic medical record. So you click on, so it's called NeoSource, Neonatal Resource, that's what it is. And all our guidelines, our policies, and how we work, what's our function, and any quality improvement project that comes up, we would put that on NeoSource. And we created the link on the electronic health record, and from that one click at the bedside for the nurse who's taking care of that patient, they would know, okay, who is the person who is involved with this quality improvement project? How do I contact them? What are the goals of this quality improvement project, and what am I actually doing at the bedside? So that was really, really helpful, and I can share what we do with the group. If anybody is interested, we can do it offline. But that's something which really helped us. Liz?
I believe the question was how we get the information out to the staff.
Or just challenges in general that you've encountered?
Okay, so we have quite a few avenues in addition to the NeoSource. We have bulletin boards. We get the information out in staff meetings. As the quality improvement coordinator, we've established a pathway for an official education that the nurse educators develop, and they get it out to the staff, and then the project team has a record of who all has been educated on it. Having me being a bedside nurse with experience in our unit and then moving into this role, because I had this rapport established with the staff, they're not afraid, or there's no barriers for them to come to me and be like, hey, I heard about this, I don't really know what it is. It's kind of been a very good liaison position for me to be there. They come to me, they tell me problems they're finding out there, they tell me their ideas. But I walk the halls, I round with the nurses and the respiratory therapists and all the people that are out there, and we talk about their problems, we talk about the projects, and when they're not unsure what to do, I remind them, oh hey, it's over here, it's on the NeoSource. We put out a quality newsletter every other month that is going to the staff, it's going to leadership, it's going to our advanced practice team, it's going to anybody that has a role in our NICU gets this in their email, and showing them new projects that came up this month, charters that we approved, projects that had great results, projects that need a little reminder that, hey, did you remember we were doing this, and to forward that along. We also have the quarterly meeting at the med school, the NeoQuip. And do you want to talk about that one?
Sure. Yeah. So awareness is the other, the main issue. So I think one thing which we also added was what we call as NeoQuip, or Neonatal Quality Improvement Presentations. We have 4 neonatal intensive care units within our system, and we cover about 20,000 deliveries within that system. And we have 4 NICUs. There are 4 different flavors of NICUs, and they all have quality improvement projects. And so what we try to do every quarter is pick a theme. This month it might be respiratory. Next quarter it would be follow-up. The third month it would be infections, things like that. And we'll collate all the quality improvement projects which are going on in all these 4 NICUs and present together. So that way, people who are interested in it can have a discussion about, okay, I do it this way in this hospital, we do it this way in another hospital. Can we combine forces? Can we learn from each other? And that has been really helpful. Yeah.
One of the biggest obstacles that we've really worked this year on is just establishing the accountability for the project. Dr. Jaleel mentioned earlier that, these projects, these people were doing it in their extra time, and when something more pressing came along, their quality might go to the back, but when I came in and started having the responsibility of coordinating it, I'm following up with these people on a regular basis, probably more regularly than they would like. Asking them, where's your data this month? What do you need from me? Hey, it's time for you to present. What can I do to get your presentation together? And I had lots of groups say, I'm just so glad you started asking me, because it made it a priority for them. Even if it didn't take a whole lot of their time to do, just having that little nudge push that along. Additionally, when we started asking for them to report to us, one of the other things that came up was that projects realized that their project has been going on a few years, and maybe their measures aren't exactly what they're measuring anymore, or maybe the goal has changed, but they hadn't had like a formal evaluation looking at what they were doing. So it gave them an opportunity to review their charters and decide what their purpose really was, and gave them more of a focus. So the accountability piece of having somebody asking for their data was real important to them.
Shannon Medical Center?
Okay, well, we don't have too much trouble with staff buy-in as long as we don't require them to do any work. It's just fine. So, in all honesty, that's true for the on the physician side. Everybody wants to improve and do better. They don't mind at all the quality. They don't mind. They'll and talk about mistakes. Those all things are just fine. The main thing is having the ability to get the data in and to analyze it, and that fell onto Stacie, and I'll let her take it from there.
In terms of communicating with the staff, everything that's going on, it's not as challenging as it is in the larger facilities, because there aren't near as much staff, and they are participating in most of those projects because there aren't that many of them. But we do use a dashboard reporting system in which we share all that data with everybody that will let us share it with them each month. We do it at staff unit meetings. We do it at physician and interdisciplinary subcommittee meetings, so basically just not the physician leadership or other people like that, all of the providers in that system, so they all know. And then we share that at our QAPI as well. And I didn't mention when I was doing my introduction that we actually do all of our QAPI together, and in a smaller institution that kind of makes sense. So it's called Perinatal QAPI, and we do a maternal part of it, a neonatal part of it, and then we also have our breastfeeding in there as well, because it's really all the same interdisciplinary players, and getting them to more than one meeting a month to discuss QAPI can be challenging in addition to all the other things you're working on. So what we do is just have them all meet together and kind of do it in stages so we can get all of that covered. In terms of buy-in from our staff, I think we work hard to help them understand that why behind why they're doing what they're doing. For them, sometimes it's more of a challenge to participate in it just because there is limited staff. Not everyone is always participating in it, but we try to help them understand the why behind it. And then lastly, one of the challenges that we had early on was really keeping the momentum going. You know, we always say in rural health, we don't have enough people, we don't have enough resources. So those things like drills, like simulations, like meeting attendance, all those things can be a challenge. So we've really tried to hardwire in things that work for us, like setting a drill schedule and an education schedule, you know, a whole year in advance. So we don't drop the ball, because we experienced that personally. We had good intentions to do that drill next month, but then the labor and delivery nurse manager, you know, was in patient care that day, so we couldn't do that drill because she was the one that was going to lead it, and we found ourselves not being consistent. So really hardwiring all that in some type of scheduled system was very helpful. And then I wanted to say just one thing quickly. Probably the biggest thing that's helped us the most was adding one full-time FTE for a perinatal quality specialist. And you know, we all know FTEs are hard to come by. You can't just ask for one and you receive them for sure. So what we did was, I should say steal, but reallocate is probably the more appropriate word to use if there are any financial people in the room. And I took half of an FTE from labor and delivery and half of an FTE from NICU to make a full-time quality specialist that lives with us within our building. We're a 3-story building separate from the main hospital, and so that person, her only job is perinatal quality. So while the rest of us are running around her, changing hats from day to day, she can pull us back in and remind us what we're supposed to be doing and remind us where we're supposed to be making this progress. And we do a huddle, and we call it a huddle, but it's not the event huddle. That's one of the things that we want to work on for adverse events and unexpected outcomes. But we actually huddle together, like, send out a text, hey, everybody, gather in Stacey's office. We need to spend 15 minutes talking about the whatever, or we're not going to get to the next goal that we have in mind by the date we have in mind. So we huddle ourselves kind of as a leadership team to make sure make sure our projects are on track, because, we can't all show up at every meeting, and we don't want to stop that momentum or go the wrong way because someone wasn't able to be there that day. So we have to be flexible in having those quick little impromptu meetings or task force or whatever you want to call them so that we can go ahead and move forward. So if you can figure out a way to get someone to dedicate their time just to perinatal quality in a small organization, that was huge. I would not ever be able to do that without that position.
I think another thing for us, for the physician staff, is that I go to every OB meeting, and the head of OB comes to all of our pediatric meetings, and we really try to be a team. We're not out against each other because we're all going to get sued together. So the better and it's worked out really, and that's been really helpful. Because it's not always that way. There's always times there's personalities, but in general, we're a great team, and that's been a lot better.
Great. How about Peterson Memorial?
I was going to share earlier that the maternal designation process, as daunting and scary as that was really helpful to bolster our QAPI program. I learned a lot from the ACOG surveyors that came to our hospital, and I know some of y'all are out there, and thank you very much. But they really had really good feedback for us in what we could do to improve our QAPI program. So those of you who haven't gone through the maternal designation, I invite y'all to just go ahead and get it done. Once you get it all done and out of, it just feels so much better. To get that out. But there's a lot of growth and development of your QAPI program to be had by going through the process, and I really appreciated that. Because we are a department that is in charge of neonatal and maternal care, Melissa and I were going crazy trying to keep up with all the audits, because we had neonatal metrics and we had maternal metrics, and that's a lot for poor Melissa to collect. And so what we've done recently is that we've enlisted the help of our shift leaders, the charge nurses, and each one was assigned a metric that they do all the data collection. And it really helps to get that done at the bedside, because now they're aware of what the metric is and what the expectation is, and they can in real time catch the fallouts and re-educate and coach the staff to, this is how was expected, and this is what didn't happen, and just, food for thought for the future. So that's helped a lot. I guess that's all I was going to share.
Well, I was going to say, we also did the same thing that you're doing, is we combined our neonatal and maternal into a perinatal, and I think it's a lot richer for everyone to be at the same table and having those conversations, because we are not really isolated as we're artificially doing that here, and I think that's really helped the quality, and we're working together and getting our simulations and our teams and our multidisciplinary, everyone coming together and for the highest quality with the resources and the place that we're at. And our biggest struggle, I don't know if we answered that earlier, I think has been getting anesthesia with some of these quality initiatives and helping them to define their roles and participating in that. They show up when we need anesthesia, but when we need critical care assistance, sometimes I think that's where we're lacking in our smaller facility, and still trying to figure that out.
Great.
Yeah, small rural facilities don't have dedicated anesthesia, so you're dealing with a group of anesthesia that cover the whole house, and so there's access issues sometimes if they're in a big vascular case and we need them in OB. there's a certain degree of backup, but then they're not trained like we are as far as management of hemorrhage and stuff like that. So engaging them, bringing them in so that we do all the same training is going to be helpful when we get there. So.
Great. So I'm going to put each panelist on the spot for a 1 minute or less elevator pitch about a pearl for everybody out there. While they're thinking about that, can everybody who's maternal raise their hand? Everybody who's maternal who's had their survey through ACOG or TTAF, keep your hand up. Those are your mentors. So look whose hand's up right now, and if you need help, ask for help. We've done that with our Level 4 center. We've reached out to centers to do that. But the people that just had their hands up have been through that process. They know the things you need to have in place. How about neonatal? Hands up? You guys are, who's been through the survey the second time? What's starting, I guess. So, oh, there we go. So neonatal's a little more fleshed out. Maternal's a little more challenging, obviously. So quick elevator pitch, one pearl to everybody out here who's developing a quality program, and then we'll open up for questions.
Okay. I was not prepared for this, but I'll try. So I think there is usually a malalignment between what the hospital wants, what the leadership wants, and what we want in the NICU. For example, the hospital wants PCO 6, I think it's called, which is unexplained consequences, complications for newborn. I can't do anything about it when I'm sitting in the NICU. The damage is already done, but yes, that's one of our measures. And there are multiple malalignments like that. What I'm worried about is how can I get this baby from the delivery room without intubating the baby and getting the baby up on CPAP? Or how can I get this mom of a baby with neonatal abstinence syndrome to come sit with a baby and hold the baby and do that, and do kangaroo care, breastfeeding, and things like that. So I think there can be a disconnect sometimes between the leadership and the staff at the bedside. So one thing which we could do is try to align ourselves to meet the goals as well. So one of the things which we did was, yes, CLABSI is a big thing, and they want to reduce it, but we were seeing a significantly high number of coagulase-negative staph late onset infections. So we aligned those two together and say, okay, we are going to work on reducing coagulase-negative staph infections and contamination of the blood culture that we do, samples that we send. And so that eventually will help us in getting our CLABSI rate low as well. So aligning that way, I think helps.
Good. Ms. Moore?
I would just want to say that I know not everybody here, I've heard you saying, we don't have a big facility like you, we don't have all of the resources you have. I just really want to encourage you that you don't have to have a big hospital with all of the resources to make a change and to make care better. You take those small steps that you can do and you run with it, and you can just build another step on after you get the first one. We have a team that was trying to work on, or is working on, discharge, improving our discharge process, and it was just getting bigger and bigger, and there were so many things they just wanted to just attack it all, and then it just got so big we couldn't figure out where to start. And so we dialed it all the way back to, okay, what is the first thing you want to do? And the first thing we want to do is make sure everybody's getting their congenital heart screen at the right time, and that's going to be the first small win, and then we can move on to the next one. And you don't need a whole big academic system to do a small project like that and make a difference.
Dr. Wehner?
Perinatal quality specialist. That's number one, what you got to have, because that person keeps you focused. And not only that, she makes sure you finish whatever you started. So I will say that's got to be who you got to have first.
Okay. So
I would agree. Dr. Wehner stole mine, but the other thing I would say is a lot of quality programs or quality initiatives fail because people don't close the loop on them. They begin that monitoring, they get it going, and then that person who's leading that charge quits or gets promoted or whatever happens, and then it dies right there, and you go back and look for it in 6 months, and some people in that unit had no idea they were ever doing it. It's kind of amazing the way they disappear sometimes. So find a very simplistic way to make sure you have that loop closure. And for us, that is at our CWAPI committee. It sometimes feels like we're beating a dead horse because we'll bring it back around. And we have a very simple little form we use at our institution or within our perinatal CWAPI, but we bring it back around, and the last discussion point on that issue is, can this close, can this not close? And we go around the whole interdisciplinary group and have everyone give a nod and say, yeah, that one can close. And we may still be monitoring it down the road, of course, to make sure it's hardwired in, but we make sure you get that closer. You just don't, it doesn't just drop off the face of the earth.
Ms. Hoffman?
Just keep in focus that we're all showing up to work every day to keep our mothers and our babies healthy and safe. And so if everybody, when you're integrating teams, the NICU team, the ED staff, the ICU nurse, the anesthesiologist, everybody's coming together, just keep that, if everybody keeps that in their focus, then the differences of opinions or the priority challenges, it just doesn't matter if you're all focused on affecting safe and a quality delivery of care for our moms and babies.
Make sure you have a provider champion that will help support it, because a lot of these processes, I think, are driven on the nursing side of things. I think they're more used to that than we are on the provider side. And we're lucky at Peterson that I think we have pretty good buy-in from our providers. Again, we're very small and we're all one group, and so we know how each other thinks. But I think in bigger groups where you have private docs, and I've been in other practices like that, and trying to roll this out, you really need to have people that know the message, the why behind the what, because that's the biggest thing. Tell me why I'm doing this. And if you keep your patient number one, I think that will always, you'll make the right decision and head in the right direction.
So we'll take questions in just a second. While everybody's getting to the microphone, I'll just summarize the 7 pearls. Alignment, make sure we're all aligned on what we're trying to accomplish. Don't show off too much, so break it down to a smaller project if it seems too daunting. QI specialist, have somebody designated or try to get an FTE for that. Close the loop on a project and make it a simple process so it's not daunting. Always keep the eye on the ball, focus, have a vision where we're going to improve health of mothers and babies, and keep that focused all the time, and then have a provider champion. And then last, hands up for the maternal people who've been surveyed. Those are your mentors. Go to them today, get their names, contact information. They're going to help you set your CWAPI up for maternal side at least, and we all have it for neonatal right now. So questions from the audience for our panelists. Everybody wants to go home. Well, with that, I think we can give our panelists a round of applause. And Dr. Spear is going to come up and make a few remarks, and then we'll be heading to the simulations. And Ms. Hoffman will be running one of our simulations with us this afternoon.